All about typhoid fever. Ather names are gastric fever, enteric fever, abdominal typhus, infantile remittant fever, slow fever, nervous fever, and pythogenic fever. Typhoid fever is a bacterial infection that can spread throughout the body, affecting many organs. Without prompt treatment, it can cause serious complications and can be fatal. It's caused by a bacterium called Salmonella typhi, which is related to the bacteria that cause Salmonella food poisoning. Typhoid fever is highly contagious. An infected person can pass the bacteria out of their body in their poo, stools, or, less commonly, in their pee, urine. If someone else eats food or drinks water that's been contaminated with a small amount of infected poo or urine, they can become infected with the bacteria and develop typhoid fever. Signs and symptoms. Classically, the progression of untreated typhoid fever is divided into 4 distinct stages, each lasting about a week. Over the course of these stages, the patient becomes exhausted and emaciated. 1. In the first week, the body temperature rises slowly, and fever fluctuations are seen with relative bradycardia, faggot sign, malaise, headache, and cough. B. A bloody nose, epistaxis, is seen in a quarter of cases. C. Abdominal pain is also possible. D. A decrease in the number of circulating white blood cells, leukopenia, occurs with eosinopenia and relative lymphocytosis. Blood cultures are positive for Salmonella enterica subsp enterica or S. paratyphi. F. The Whittle test is usually negative in the first week. 2. In the second week, the person is often too tired to get up. B. High fever in plateau around 40 degrees Celsius 104 degrees Fahrenheit. C. Bradycardia, sphygmothermic dissociation or faggot sign, classically with a dicrotic pulse wave. D. Delirium can occur, where the patient is often calm, but sometimes becomes agitated. This delirium has led to typhoid receiving the nickname nervous fever. Rose spots appear on the lower chest and abdomen in around a third of patients. F. Runky, rattling breathing sounds, are heard in the base of the lungs. G. The abdomen is distended and painful in the right lower quadrant, where a rumbling sound can be heard. H. Diarrhea can occur in this stage, but constipation is also common. I. The spleen and liver are enlarged, hepatosplenomegaly, and tender, and liver transaminases are elevated. J. The Whittle test is strongly positive, with anti-O and anti-H antibodies. K. Blood cultures are sometimes still positive at this stage. L. The major symptom of this fever is that it usually rises in the afternoon up to the first and second week. 3. In the third week of typhoid fever, a number of complications can occur. A. Intestinal hemorrhage due to bleeding in congested Peyer's patches occurs. This can be very serious, but is usually not fatal. B. Intestinal perforation in the distal ileum is a very serious complication and is frequently fatal. It may occur without alarming symptoms until septicemia or diffuse peritonitis sets in. C. Encephalitis. D. Respiratory diseases such as pneumonia and acute bronchitis. E. Neuropsychiatric symptoms, described as muttering delirium or coma vigil, with picking at bedclothes or imaginary objects. F. Metastatic abscesses, cholecystitis, endocarditis, and osteitis. G. The fever is still very high and oscillates very little over 24 hours. H. Dehydration ensues, and the patient is delirious, typhoid state. I. 1/3 of affected individuals develop a macular rash on the trunk. J. Platelet count goes down slowly and the risk of bleeding rises. K. By the end of third week, the fever starts subsiding. Causes of typhoid fever. The gram-negative bacterium that causes typhoid fever is Salmonella enterica subsp enterica. The two main types of the subspecies enterica are ST1 and ST2, based on MLST subtyping scheme, which are currently widespread globally. Transmission of typhoid fever, *, unlike other strains of Salmonella, no animal carriers of typhoid are known. Humans are the only known carriers of the bacteria. *Se subsp. is spread through the fecal-oral route from individuals who are currently infected and from asymptomatic carriers of the bacteria. *An asymptomatic human carrier is an individual who is still excreting typhoid bacteria in their stool a year after the acute stage of the infection. Diagnosis of typhoid fever. One diagnosis is made by any blood, bone marrow, or stool cultures and with the Whittle test, demonstration of antibodies against Salmonella antigens O somatic and H flagellar. 2. In epidemics and less wealthy countries, after excluding malaria, dysentery, or pneumonia, a therapeutic trial time with chloramphenicol is generally undertaken while awaiting the results of the Whittle test and cultures of the blood and stool. 3. Whittle test. 1. Whittle test is used to identify specific antibodies in serum of people with typhoid by using antigen-antibody interactions. 2. In this test, the serum is mixed with a dead bacterial suspension of Salmonella having specific antigens on it. 3. If the patient's serum is carrying antibodies against those antigens, then they get attached to them, forming clumping, which indicated the positivity of the test. If clumping does not occur, then the test is negative. 3. The Whittle test is time-consuming and prone to significant false positive results. The test may also be falsely negative in the early course of illness. 4. However, unlike the Typhoid test, the Whittle test quantifies the specimen with titers. 4. Typhoid. A. The test is based on the presence of specific IgM and IgG antibodies to a specific 50 kDOMP antigen. B. This test is carried out on a cellulose nitrate membrane where a specific S-typhi outer membrane protein is attached as fixed test lines. C. It separately identifies IgM and IgG antibodies. D. IgM shows recent infection whereas IgG signifies remote infection. E. The sample pad of this kit contains colloidal gold anti-human IgG or gold anti-human IgM. F. If the sample contains IgG and IgM antibodies against those antigens, then they will react and get turned into red color. G. This complex will continue to move forward and the IgG and IgM antibodies will get attached to the first test line where IgG and IgM antigens are present, giving a pink purplish colored band. H. This complex will continue to move further and reach the control line, which consists of rabbit anti-mouse antibody which bends the mouse anti-human IgG or IgM antibodies. I. The main purpose of the control line is to indicate a proper migration and reagent color. The Typhoid test becomes positive within 2 to 3 days of infection. J. 2 colored bands indicate a positive test. Single band of control line indicates a negative test. K. Single band of first fixed line or no bands at all indicates invalid tests. L. The most important limitation of this test is that it is not quantitative and the result is only positive or negative. 5. Tubex test. 1. Tubex test contains two types of particles: brown magnetic particles coated with antigen and blue indicator particles coated with O9 antibody. 2. During the test, if antibodies are present in the serum, then they will get attached to the brown magnetic particles and settle down at the base, and the blue indicator particles remain up in the solution, giving a blue color that indicates positivity of the test. 3. If the serum does not have an antibody in it, then the blue particle gets attached to the brown particles and settled down at the bottom, giving no color to the solution, which means the test is negative and they do not have typhoid. Treatment of typhoid fever. 1. Oral rehydration therapy. The rediscovery of oral rehydration therapy in the 1960s provided a simple way to prevent many of the deaths of diarrheal diseases in general. 2. Antibiotics. A. Where resistance is uncommon, the treatment of choice is a fluoroquinolone such as ciprofloxacin. B. Otherwise, a third-generation cephalosporin such as ceftriaxone or cefotaxime is the first choice. C. Cefixime is a suitable oral alternative. D. Amoxicillin and ciprofloxacin have been commonly used to treat typhoid fever. Treatment of the disease with antibiotics reduces the case fatality rate to about 1%. Without treatment, some patients develop sustained fever, bradycardia, hepatosplenomegaly, abdominal symptoms, and occasionally, pneumonia. In white-skinned patients, pink spots, which fade on pressure, appear on the skin of the trunk in up to 20% of cases. In the third week, untreated cases may develop gastrointestinal and cerebral complications, which may prove fatal in up to 10 to 20% of cases. The highest case fatality rates are reported in children under 4 years. Around 2 to 5% of those who contract typhoid fever become chronic carriers, as bacteria persist in the biliary tract after symptoms have resolved. 3. Surgery. Surgery is usually indicated if intestinal perforation occurs. For surgical treatment, most surgeons prefer simple closure of the perforation with drainage of the peritoneum. Small bowel resection is indicated for patients with multiple perforations. If antibiotic treatment fails to eradicate the hepatobiliary carriage, the gallbladder should be resected. Cholecystectomy is not always successful in eradicating the carrier state resistance to treatment, one as resistance to ampicillin, chloramphenicol, trimethoprim-sulfamethoxazole, streptomycin is now common. These agents have not been used as first-line treatment of typhoid fever for almost 20 years. Typhoid resistant to these agents is known as multi-drug resistant typhoid. 2. Ciprofloxacin resistance is an increasing problem, especially in the Indian subcontinent and Southeast Asia. Many centers are shifting from using ciprofloxacin as the first line for treating suspected typhoid originating in 3 South America, India, Pakistan, Bangladesh, Thailand, or Vietnam. For these people, the recommended first-line treatment is ceftriaxone. 5. Also, azithromycin has been suggested to be better at treating resistant typhoid in populations than both fluoroquinolone drugs and ceftriaxone. Azithromycin significantly reduces relapse rates compared with ceftriaxone. A separate problem exists with laboratory testing for reduced susceptibility to ciprofloxacin. Current recommendations are that isolates should be tested simultaneously against ciprofloxacin, CIP, and against nalidixic acid, NaL, and that isolates that are sensitive to both CIP and NaL should be reported as sensitive to ciprofloxacin, but that isolates testing sensitive to CIP but not to NaL should be reported as reduced sensitivity to ciprofloxacin. However, an analysis of 271 isolates showed that around 18% of isolates with a reduced susceptibility to ciprofloxacin, Mike 0.125 to 1.0 mg/L, would not be picked up by this method. How this problem can be solved is not certain, because most laboratories around the world, including the West, are dependent on disk testing and cannot test for Mike's prevention of typhoid fever. A. Sanitation and hygiene are important to prevent typhoid. B. It can only spread in environments where human feces are able to come into contact with food or drinking water. C. Careful food preparation and washing of hands are crucial to prevent typhoid. D. Industrialization, and in particular, the invention of the automobile, contributed greatly to the elimination of typhoid fever, as it eliminated the public health hazards associated with having horse manure in public streets, which led to large number of flies, which are known as vectors of many pathogens, including Salmonella species E. According to statistics from the United States Centers for Disease Control and Prevention, the chlorination of drinking water has led to dramatic decreases in the transmission of typhoid fever in the United States. Vaccination of typhoid fever. 2 typhoid vaccines are licensed for use for the prevention of typhoid, the one live, oral Ty21 vaccine, sold as Vivotif by Crocell Switzerland AG. 2. The injectable typhoid polysaccharide vaccine, sold as Tifum 6 by Sanofi Pasteur and Tiferix by GlaxoSmithKline. Both are efficacious and recommended for travelers to areas where typhoid is endemic. Boosters are recommended every 5 years for the oral vaccine and every 2 years for the injectable form. An older, killed whole cell vaccine is still used in countries where the newer preparations are not available, but this vaccine is no longer recommended for use because it has a higher rate of side effects, mainly pain and inflammation at the site of the injection. To help decrease rates of typhoid fever in developing nations, the World Health Organization, WHO, endorsed the use of a vaccination program starting in 1999. Vaccinations have proven to be a great way at controlling outbreaks in high-incidence areas. Just as important, It is also very cost-effective. Vaccination prices are normally low, less than US $1 per dose. Because the price is low, poverty-stricken communities are more willing to take advantage of the vaccinations. Although vaccination programs for typhoid have proven to be effective, they alone cannot eliminate typhoid fever. The VIP's vaccine is given via injection, while the Ty21 is taken through capsules. Only people 2 years or older are recommended to be vaccinated with the VIP's vaccine. And it requires a revaccination after 2 to 3 years with a 55 to 72% vaccine efficacy. The alternative Ty21 vaccine is recommended for people 5 years or older, and has a 5-7 year duration with a 51 to 67% vaccine efficacy. The two different vaccines have been proven as a safe and effective treatment for epidemic disease control in multiple regions. A version combined with hepatitis A is also available.